Peter's here, we're all here. It is 6:31. And I will read the remote meeting paragraph to get our meeting going. Pursuant to Governor Baker's March 12th, 2020 order suspending certain provisions of the open meeting law and Governor Healy's March 29th revised order extending remote participation by all members in any meeting of a public body, this meeting of the Great Barrington Board of Health will be conducted both in person and via remote participation to the greatest extent possible. Specific information and the general guidelines for remote participation by members of the public and or parties with a right and or requirement to attend this meeting can be found on the town's website at townofgb.org. For this meeting, members of the public and committee members may attend by meeting in person, or for those who wish to do so remotely, may by following the instructions at the top of this agenda. For those who are not in person, every effort will be made to ensure that the public can adequately access the proceedings in real time via technological means. With that being said, I will call the meeting to order with a roll call vote. Peter Stanton.
Aye.
Dr. Ruby Chang.
Aye.
And I am Michael Anu, chair. Meeting is called to order. Quick point of order, I would suggest on our agenda that we move Board of Health questions and updates after our business. The other two items I think we'll quickly move through. In agreement with that? Sure. Okay. Assuming everyone's looked at the minutes, I'll look for a motion to approve the minutes from September.
Make a motion to approve the minutes from September 7th.
I second.
Roll call is Peter,
Aye.
Ruby,
Aye.
and I vote aye as well. Meeting minutes are approved. Health Department updates.
Okay, so Berkshire County Boards of Health, the fall dinner is next Thursday, October 12th. Ruby, I think you've signed up, and Peter, you're signed up as well as myself. This dinner, Susan Waite from DEP will be the presenter. She'll speak on the Sustainables Materials Recovery Program, that which one of our priorities is to apply for this year, and hopefully to get some funding for composting. So I think that presentation will be really timely and important. And if you'd like to go, please let me know.
Okay.
Last I heard from Laura that Laura Kitros, the registration was almost under what they would need to continue with the dinner. So I think they need at least 40 people to participate. And I think they're just under that. So
Okay.
I'll let you know if it's canceled, but
All right, I'll see. I've got Mr. Mon that night, so
okay.
unfortunately.
Right, so it's always a nice meal and an interesting topic.
Mm-hmm.
So the Western Mass Public Health Association, I just wanted to let you know that I was recently voted in as a member of this working group. We meet quarterly and we discuss things like the Totally Title V conference, statewide initiatives. There's always a representative from DPH at that meeting. Scott Cazella is usually the representative, and it's just a chance to meet with colleagues from the Pioneer Valley and FERCOG. So can start reporting back on those meetings. Yeah.
Okay,
And that's all I had for health department updates.
very good. We'll move on to our first order of business, which is hearing from Chris Horton, and he is the Berkshire Mosquito Control District representative.
Thank you for coming.
Thanks for inviting me. So I'm here because Ruby reached out to me and had some questions about mosquito control, state-sponsored mosquito control. And then Rebecca invited me to this meeting. So I'm the superintendent of Berkshire County Mosquito Control Project, and we supply comprehensive mosquito control services and mosquito-borne disease surveillance for towns in Berkshire County. We use an approach, a scientific approach that's standard pretty much throughout the country. An integrated pest management approach whereby we learn a lot about the pest and focus on all its vulnerabilities as each stage of its life cycle, and use approved methods to combat it at each of those stages. So with mosquitoes, we're looking at their breeding location. We're looking at their larval stage. We're looking at their adult stage. And we're looking at, in general, a source reduction of breeding habitat. So those are the major components of what we do. And the way a town would participate would be to basically run it through the select board. It would be voted on at a town meeting or by a town council. And then it would initiate enrollment, and the services would be paid for out of state aid assessments to the town. And the way that works is we set a budget, and the budget is distributed to member towns based on a formula from Department of Revenue. So it would be based on population, land area, and equalized tax valuation for the town.
Mm.
So those three factors would be how the budget is distributed among member towns.
I see.
Yeah.
So that comes out of state aid, you said?
Yeah, it's in the unrestricted state aid category.
Ah.
Yeah,
Okay.
So does the town pay anything?
No, the entire amount comes out of the unrestricted state aid, but the characteristics of unrestricted state aid are that once that's turned over to the town, they can use that for any purpose they want. So it's after it's in the town's hands, it's unrestricted. If you joined mosquito control, there would be an assessment to that amount before it got to the town.
Oh, so they'd levy it before.
Right.
Okay, yeah. All right. For something like Barrington, what would be a rough idea of the cost?
It's kind of hard to determine. So I could say what I think it would cost to get started here. So the first thing we would do is to map your breeding habitat. So we have a GIS system whereby we map breeding habitat, and then we do continual surveillance on that breeding habitat to see what's happening, to see if there's larval development, to see if there's standing water, to see if there are adult mosquitoes. So that process is the initial process. So once that's in place, that carries on, but it's a lot of work up front.
Does that cover public and private land, or just any land?
We can work on public and private land.
So for landowners, do you have to get permission to go in there, or?
We actually have statutory authority to
Go in?
trespass on private land.
Oh, interesting.
We really don't exert that.
Right.
It's if there were a mosquito issue that was for instance, like a public health concern, we do have authority to go and address that on public or private land.
Okay.
But in terms of how much it would cost for the town, I can say that I would add a certain amount to the budget. I think it usually amounts to less than $5 per capita in the town. But then when that is distributed through the formula, it changes it somewhat. And especially out in this part of the state, because we have rural towns with large land area, low real estate values. And then we have towns with high population and high real estate values. And the formula puts the burden on the population areas and real estate areas. So that's the way it works, and the formula is statutory, so we can't really do anything about that. That would be a legislative change in order to change how the money is distributed in the budget.
I see.
Can you tell us who is actually monitoring the mosquito population for Triple E and West Nile
Right.
in Great Barrington right now?
So this has been an issue since I've been here for 12 years.
Mhm.
Initially, when I arrived, there was very little mosquito-borne disease surveillance in the western part of the state. So that was one of the first things that I addressed when I got here. We started a surveillance program. The surveillance we do is only in member towns,
Mhm.
because we are not allowed to use our resources outside of member towns.
Mhm.
So the problem has also been addressed somewhat by Mass DPH, who offer a limited surveillance for theoretically the entire state,
Mhm.
but it's not at the same level that we do. Everybody on that program works out of Boston, and they come out here, at a lesser level. So there would be some, theoretically, there'd be some mosquito trapping.
Mhm.
I could check on it to see what the level was. I don't have it in front of me, but there would be some surveillance trapping, but it would be limited. And then if they had disease cases, they may increase that. But I mean, we're in the business of preventing the disease
Mhm.
from getting in the human population. So I think we have a pretty robust surveillance program.
Mhm.
We submit a pool of mosquitoes for genetic testing, which is usually 50 mosquitoes.
Mhm.
And we've submitted almost 600 of those this year from 9 member towns. So
Mhm.
it's, I think, a good indication of if there is disease present and what the level is.
Mhm.
I mean, epidemiologists, they look at how many mosquitoes there are, how many mosquitoes are infected, and they watch it throughout the season to see where it's going. And that's how they make their risk assessments. So,
Mhm.
so we're trying to send a lot of mosquitoes so they can get the answer of what's going on.
I see. So what physically does the surveillance look like? So you identify spots where a mosquito habitat,
Yeah,
you go in there and then what happens?
so when we if we identify a breeding habitat, it's in the GIS system. The GIS system basically prompts us to go there and look at the water. If it's present, if there's standing water there, we actually dip the water, look for larvae. If we find larvae, then we would respond. We use an organic larvicide, a bacterial product that we would put in the water. That's 100% effective. But it's a lot of legwork and a lot of groundwork. And through the course of the season, some sites are accessible in the spring and they aren't later in the season. For instance, woodland pools or cattail swamps can grow up so that you just can't move in there. So larval control is not the end all in mosquito control. I mean, it's a process we use when possible. But there will be mosquitoes, there will be adult mosquitoes, and that's a given because we just can't cover all the larval habitat.
Now that larvicide you use, is that if my memory serves, it's specifically targeted for mosquito larvae, or is it?
Yeah, so we use the active ingredient. Actually, there are 2 products that we use now. One is Bacillus thuringiensis israelensis, and that is specific to mosquito larvae. The mosquito has a specific pH in their midgut, and that bacteria is lethal in that pH range. So other insects that are developing in that same area develop unharmed, but the mosquito larvae are taken out. And we also, there's a spinosad product, which is, that's another naturally occurring soil bacterium. And that uses a different mode of action, but it's not specific to mosquito larvae. So we use that in certain instances and BTI and others. Yeah,
Is one more expensive than the other?
spinosad is more expensive. And I think the reason for that is that it just came on the market a few years ago, and we're always looking for rotational products. Insects are prone to developing resistance to pesticides. So with a rotation, you can break up any resistance that's forming. If you use one product at this point, and then another product the next point, the resistant population will be affected by one or the other.
Okay,
And the same thing goes with all the products we use.
okay. So that's the larva, I'm sorry, we're gonna say something?
No, go ahead.
Okay, so that's the larva approach. Then as you say, there's still mosquitoes, adult mosquitoes in
Yeah.
there.
So then we'll have adult mosquito. So really the only thing we can do with adult mosquitoes is use of a insecticide. We use a synthetic pyrethroid product, and we also use a natural pyrethrum, which is organically certified, can be used around organic farms. But that process is done through what they call an ultra low volume application. So we have special equipment that puts out aerosol of microscopic particles of the insecticide designed to target mosquitoes. We do this between dusk and dawn to mitigate non-target insects. Generally, they're not active in the middle of the night while mosquitoes are. And the amount that we're putting out is metered to the mosquito population for a distance of 300 feet from our equipment. So it's a very small application, and the lifespan of the product is very short. The product breaks down within a day's time, and it doesn't leave a residue in the environment. So it's in some ways it's I mean it's kind of like a snapshot. So if you have a situation where you want to get rid of the mosquitoes in a certain area, you can do it. It's not going to leave a residue. Other mosquitoes can be there the next week, or you might not be successful at that application, but you're not building a pesticide in the environment, and the pesticides you're not gaining a residual, and the pesticide's not persistent in the environment. So every time you're starting over, that's the system we use. So it is a pesticide, and I understand people have concerns for pesticides, but that's how we mitigate the risk of using a pesticide in the environment.
And how do you determine when to use a pesticide?
So generally, we set a threshold for population of potential vector species. So there are certain species we're looking at that are the most likely vectors of the diseases we have here. So we do the surveillance trapping. We have traps out constantly in the town, and depending on what those traps are catching, that gives us an idea of the population size. And then a percentage of that population is sent for testing for disease. So we would recommend an intervention on adult mosquitoes if you have a high population of vectors, or if a lower population, but there's disease present in that population. Because the presence of the vectors is a risk in itself. And it's it's not like a light switch. I mean, you can't steer that population instantly. You have to be, so we're starting with our source reduction, then we're going to our larval control, then we're going to our adult control, and we're increasing our efforts depending on how successful we are. If there aren't mosquitoes, we aren't gonna be doing adult control. If there aren't larvae, we won't be doing larval control. But if there are all those things, we would want to keep increasing the pressure. And if disease is present, then we would try to do everything we could until we didn't find the conditions that are favorable for humans to get sick.
And for adult control, do you take those actions as you see them arise, or do you get approval from the town, or?
So it's different by town. So this was a question me and Ruby spoke about earlier. Some towns have been in our project since we started in 1946. So they've been in that whole time, and basically they ask for reports on our activities, and they say, do what you have to do. Other towns, the Board of Health has oversight over mosquito control, and any product we use or any adult control, or even possibly the level of surveillance, would be determined by an agreement between us and the Board of Health.
I see.
So for instance, some towns, any spray I would make a recommendation to the Board of Health, and the Board of Health would decide, based on their own appraisal of what was going on, whether or not to do adult control at that area.
The method for adult control is you go into those areas where the populations are, and
So we're using truck mounted equipment. So it's would be spraying on roads. There is the possibility of, moving off roads, but that would be a different application method. And we don't do a lot of that because our manpower is not at that level. I mean, that's expensive, time consuming. And, for instance, there are districts in the eastern part of the state that do treatments in public areas where, people kind of congregate like that, but that's we still want to do it between dusk and dawn, so we're missing pollinators and stuff. And in order to have the equipment and the time to do that, you have to have more staff than we have. So it's possible, but at this stage we don't do much of it.
generally on the roadways.
But then it depends on the situation too. I mean, we're always balancing our priorities. So if there's a situation that warrants it, we could change our priorities, and we try and move in a direction to steer away from the end point of a person getting sick. So.
I see. Okay.
Can you try to give us an idea of the effectiveness of mosquito control over disease of humans?
There have been studies done. I could probably get you some studies in terms of, there was one done in Chicago recently, whereby they did ULV treatments in response to a West Nile condition that was developing. And what they did was, it's very hard to track the success of a ULV treatment because there are always mosquitoes developing in the background. So when you take these mosquitoes out, other mosquitoes could be developing. And in the past, we've been criticized for doing a ULV treatment, and the next trapping session, they catch more mosquitoes than they had before the ULV treatment. And what's the explanation for that? Well, this study was designed to look into that So what they did was they trapped mosquitoes before and after. And what they found was that the mosquitoes, a higher percentage of them after the ULV treatment were, I think the term was non-parous. They had never taken a blood meal and produced eggs.
Mhm.
So what that indicated was that the older mosquitoes who had been through a breeding cycle were eliminated from the population.
Mhm.
And when they had these younger mosquitoes, that the risk is in that older population that's already taken that blood meal, because that's where they're gonna pick the virus up. So you're changing the age structure of the population,
Mhm.
and they proved that through this study.
Mhm.
And that even if the mosquito population is not eliminated,
Mhm.
you're still doing the job of reducing the risk of infected mosquitoes being in the population.
Mhm.
So I can get you that study. It just came out in July of this year.
Mhm.
But in terms of larval control, anywhere we go, that's a defined area where we find larvae and we apply the BTI,
Mhm.
that is 100% effective. I can say that. We have never found larvae at a place where we treated properly. The product works. We have tested for resistance. We don't have resistance in this area.
Mhm.
CDC helped us with that.
Mhm.
The other issues are, though, we have a budget. So it's a big world and a budget goes so far. So we have to try and point it in the right direction all the time. And that's hard to do. And we're dealing with nature,
Mhm.
and nature can get big very fast.
Mhm.
And I mean, this summer it did.
Mhm.
So when the Housatonic River floods into the floodplains,
Mhm.
those floodplains are all seeded with eggs.
Really?
And they all start development at the same time,
Mhm.
and they all hatch at the same time. And that's, overwhelming for this area, because that's a big problem.
Mhm.
When you're talking about larval control, you're talking about thousands of acres instead of hundreds of acres. So there are certain instances where mosquito populations do surge ahead, but with continued effort, we are able to reduce them and get them back to normal, below our thresholds.
Right. Do you have any data on comparing those towns that are using your services and those towns that do not use your services? And the morbidity to the citizens, disease incidents?
So our numbers are very small in Massachusetts.
Mhm.
The number of West Nile cases we get is small.
Mhm.
So statistically speaking, I don't know if it's super significant, but I will say that I don't want to identify any towns or cities, but there are areas in the Boston area that do not use adult control,
Mhm.
and they have higher human incidence of West Nile. And I don't know if they would anyways.
Mhm.
I mean, there's a possibility that they would anyway,
Mhm.
but in California, they have had West Nile outbreaks. In Dallas, they had a large outbreak,
Mhm.
and they, through the use of adult control, they were able to stop the outbreak. They had a significant finding
Epidemiology.
epidemiologically. But they did have significant, basically it stopped the human cases after they got rid of those. It was like a high level of infected mosquitoes, and after they reduced that, they didn't get to human cases anymore.
Yeah.
And that's been shown in Chicago. And I also, I don't think they did I didn't get the final figure, but there was a large West Nile outbreak in Maricopa County, Arizona
Mhm,
in 2021 or 2022,
mhm,
2021, I think it was. But they had 106 deaths,
mhm.
1,600 West Nile cases in one county in Arizona. So it was, I don't know what I'm sure it's being studied completely now, because
Mhm.
that's like the biggest outbreak ever. I mean,
Wow.
that dwarfs anything that we've had in the East, even in New York City where it came from.
Mhm,
The agreed upon system is exactly what we do. We follow the Center for Disease Control recommendations for West Nile virus surveillance and control. So
mhm,
whatever the science is, that's what we are gonna do. And we're overseen by, at the state level by, state mosquito control board and, Mass DPH. So, whatever the current science is, they make sure that we're on track with what their recommendations are.
mhm. So now Berkshire County is considered moderate
Right.
risk. What do you say about that? Did you expect it? Did you expect us to be in the moderate risk category?
Well, there's not, I don't, I mean, privately, I might guess what the season is gonna be, but that's really not panned out in the past. You never know what's gonna happen. So the disease burden is determined by so many moving parts.
Mhm,
First, the bird population, what's the level of infection in the bird population that's coming in?
mhm,
You never know that before the season starts.
mhm,
And what the mosquito population is actually gonna be is very difficult to determine.
mhm,
And then, your weather is gonna have a huge impact on your mosquito population.
mhm,
And it also affects the development of West Nile. Infections occur a lot easier in hot conditions.
mhm,
The birds get infected easier, the mosquitoes, take the infection from birds easier in
mhm.
the hotter, conditions. So there are a lot of moving parts, and I think the surveillance, the better the surveillance, the more accurate you are at seeing, because when we detect it, we're at a certain level, and then we start increasing our steps
Mhm.
because it gets bigger from the first time we detect it. Then it goes between the birds and mosquitoes and gets larger through the rest of the season. So we try to detect it early, and we try to intervene at every opportunity, and then, try to make it plateau or
Mhm.
reduce it or disappear, or at least protect the human population.
Can you comment on the Berkshire County having, I think it's like the West Nile positive specimens for like 161? The most recent, I guess they come out weekly,
Yep.
the data. Is that unusual?
This is a fairly active year. One thing I've noticed this year is a lot of mosquitoes.
Mhm,
The vector mosquitoes that we're looking at, the Culex mosquitoes, the last couple of years have been very low years for those
Mhm.
mosquitoes.
mhm,
This year, they've come back with a vengeance. I mean, and we submitted more mosquitoes because we've caught more. And
mhm.
that's what we would do. I mean, and, we really, we had one of the earliest isolations in the state, actually, and that can also be an indicator that the season would be significant, because it's starting and getting bigger.
Mhm,
But in terms of our positivity
mhm,
compared to the statewide positivity,
mhm.
we're high.
Yeah.
I mean, we are higher than the state average,
Mhm,
for the number of samples that have been sent and the number of positives that have been recorded.
mhm.
We have a high positivity compared to that.
Um, is there a level where you say, oh, this county is in trouble, or
Well,
something should be done?
I mean, we have that for our towns. In terms of the county,
Or let's say town, let's say
Yeah.
just a,
if a town is, if we see continued positive findings
mhm,
at the same site,
mhm,
first if they're early, and then there's continued findings at that same site,
mhm,
and especially if they're followed up weekly,
mhm,
that's of real concern. Then we would really do an aggressive approach or
Mhm.
make recommendations for an aggressive approach. Because that's another factor of surveillance. We're trying to find the most likely foci of these
mhm,
outbreaks. So you're looking for a place where you're gonna have the vector mosquitoes and the bird population together.
mhm,
And when we see something happen there, we try to reduce the mosquito population in that spot.
mhm,
And if we have those foci properly, I think we're making a difference.
mhm,
For instance, the recommendation we usually have is for a West Nile virus isolation, for a adult mosquito control, we would do a 1 mile roads in a 1 mile radius of that,
mhm,
which is the theoretical flight range of the vector mosquitoes.
mhm.
So we're trying to use our resources as accurately as possible.
Mhm. As you all know, West Nile is a virus that my past experience is mainly associated with immunocompromised people or people elderly. They tend to have more disease. They tend to have more and more mortality. And there are many cases where healthy people can have West Nile and never know they had it. Really, because they mainly have muscle aches, they may have some flu symptoms, and they are out of condition for a while, a couple days, and they feel better, and they never go see the doctor. And the doctor never tests them for it, because if you have a mild disease, why should I test you for it? So the prevalence of West Nile virus, and triple E for that matter, may not be fully detected in our population.
I think you're right. And an example of that was the article I read about Maricopa County in Arizona.
Mhm,
They extrapolated the actual number of infections from the number of confirmed human cases.
mhm,
And it was, I mean, like a few percent, less than 5% are actually the confirmed cases.
mhm.
So they extrapolated those infections, and the infections were, in the tens of thousands in that county.
Wow.
And those people, recovered, and they didn't. But the problem is, it's also a virus, and viruses are simple and they change. And, that's cause for concern.
Mhm,
They find, for instance, in the Eastern equine, they have different lineages
mhm,
of the same virus.
mhm.
And, they come from different areas, and they potentially could have different characteristics, at some point.
So would you say that even though there's 3 documented human cases in Massachusetts right now, there could be more
I-
that are not tested for?
Right. Right. I don't really know that world,
Yeah, yeah, it's-
medical system
Right,
and
it's really
testing people
unfair to
and
ask
communicable.
you.
But it's, but based historically, when they say that, a small percentage of people who are infected
Mhm,
will develop serious illness,
mhm,
then yeah, I would say it was underreported.
mhm,
And the fact that we are catching the mosquitoes, with the virus present, which
Mhm.
we can confirm, and that the epidemiologists from
Mhm.
DPH
Mhm,
say we're at a certain risk level for infection with the disease,
mhm,
I accept their, because they have a scientific method where they're calculating that, so
mhm.
I accept their, conclusion that we would be at moderate risk now.
So when the DPH says we're in moderate risk, what do they expect each town to be doing? Is there a difference between what we do when it's low risk versus moderate risk versus high risk? What is the difference?
So they do have recommendations, but one of the recommendations is to participate in mosquito control. I don't want to sound like I'm selling you, but it's when you participate in mosquito control, you are doing surveillance and you are taking steps to reduce the mosquito population. So we are going to do everything we can to keep the mosquito population in check. If there's virus present, we're going to focus on those areas.
Mhm,
If it gets big or if there's problems, if we start getting human cases,
mhm,
then we're going to call for more resources.
mhm,
And that brings in, that's when state DPH and, there would be theoretically funding and expertise and other things that would come in to handle the situation when it got above a level of what our budget could
Mhm.
handle.
mhm.
So but in terms of DPH doesn't really direct us. I mean, we have directions for mosquito control, which set benchmarks for our methods, our surveillance, and what comes out of that is how we address our how we use our resources.
So if you make a recommendation to a town and the town says, we don't want to do this, we don't want spraying.
Mhm.
Or private home said, I don't want you near my neighborhood. What do you do in those cases?
So there is a statutory process that a person can go through to basically you fill out an application with the state that says, I don't want to be involved in pesticide, wide area pesticide application of the state.
Mhm,
And your property would go on file
mhm,
and in our GIS system, when we go out, that property would be delineated on our map and we have equipment that would give us a warning tone if we were in the range of that property, so we wouldn't
Don't go
apply
near.
adult pesticide in that area.
Got it.
If I mean, for instance, if the town or if the Board of Health didn't want to apply pesticide, I would only make the recommendation. I wouldn't supersede the Board of Health. The one issue we have gotten into in the past is who is going to make the call.
Mhm,
So is it going to be a select board? The select board is basically responsible for our funding.
mhm,
But I think the call on health issues should be made by a Board of Health.
mhm.
So it's important that we have one point of contact that would make that decision in the town.
Mhm.
So I would make a recommendation and then provide as much information to make an informed decision as possible.
So would you tell us before you spray for the adults?
I would make a recommendation
Uh-huh.
that we spray and the board could actually, you could set your own parameters
Mhm,
for what your, when you would spray, what your notification process would be, where you would spray,
mhm,
all those things. So I'll just give you an example. If we had a West Nile positive in an area at a certain trap site, I would recommend that we go to that trap site and spray the roads in a 1 mile radius
Mhm,
of that.
mhm,
So that's a conservative recommendation
mhm,
in the big picture of things. Nationally,
mhm.
that is like a standard response. So if it was the first isolation, or if you had one isolation in the last 10 years,
Mhm.
or if it was at the end of the year, maybe you would make the decision that no, we aren't gonna bother spraying that
Because
area because,
Frost is coming
we're almost
soon.
out.
We're
Yeah.
almost done for the season.
yeah, or really there's, it's not a mosquito year, or it doesn't look like it's going anywhere. So, but I would still make the recommendation
Mhm.
because I mean, from my standpoint, I just want to do everything that's acceptable,
Mhm,
you know, to basically cover my bases,
mhm.
you know.
Right.
Yeah.
There's a lot of, we're considered a pollinator
Pollinator community,
community.
yeah,
So many people have written to us, expressing their concern about what does mosquito spraying do
mhm,
in a pollinator city.
Right.
Can you give us any?
well, I can. Our methods, and I don't want to totally focus on the adult control part of it,
Mhm,
because there's a lot of other moving things that we're doing at the same time.
mhm,
But in terms of the pollinators, our practices are designed to minimize risk to pollinators.
mhm,
That's why we do everything dusk to dawn.
mhm,
And if we identify, beekeepers or something like that,
Mhm.
they would be in a identified, and we would not be in proximity of those hives.
mhm,
In terms of the general pollinators,
mhm,
there's been research that a bee is larger and a lot harder to kill
mhm,
with this pesticide than a
Mhm.
mosquito. So
Mhm.
that's why our dosage is
mhm,
limited to the mosquito application. So a mosquito is a soft-bodied insect,
mhm,
a bee hard-bodied insect.
mhm,
The mosquito absorbs the pesticide more readily than the bee,
mhm,
and the bee has a bigger body mass
mhm.
and could theoretically take a bigger dose.
In the towns that you've sprayed, do people complain that there's an issue with their beehives or their pollinator population?
We have not had a complaint in my 12 years.
Okay.
And actually, the state apiary inspector
Uh-huh.
teamed up with the state pesticide, the head of the state pesticide bureau,
Uh-huh.
and they wanted to investigate any reported bee kills.
Uh-huh.
So when there's a reported bee kill, they go to the site
Uh-huh.
and collect bees and identify what the source of the problem was.
Uh-huh.
And that has been going on for at least 5 years,
Mhm.
and there's been no mosquito control implication in any bee kill.
That's good to know. Thank you.
Yeah.
How about other insects?
I mean, it is a pesticide, and we are putting it out
Mhm.
at a certain rate, so I imagine there are non-targets. But insect populations are resilient, and our products are labeled by the EPA, so there is non-target research that goes into the labeling of the product.
Mhm.
So they have to determine what the effect is going to be on non-target organisms and the environment before the product can be labeled. And the rate that we're able to use it
Mhm.
is also part of that research.
Mhm.
So the product, first of all, has to perform as specified on the label. And we have to apply it at the rates specified on the label by law.
Mhm.
And the label indicates that it's not gonna cause significant damage to the environment or non-target insects
Okay.
or animals. I mean, a lot of times we've had criticism from people that if you read the label, they say this product is highly toxic to fish and bees,
Mhm.
aquatic organisms.
Mhm.
That's true, but we aren't applying it to aquatic organisms or bees
Mhm.
in
I mean,
quantities
the
that would,
concentration is much
right,
less.
the dose is there's a statement, ancient statement that the dose is the poison, you know, and the dosing is the way we
Mhm.
mitigate the risk.
Mhm. Do you have any other questions?
I don't. Seems quite thorough.
So moving forward, we're hoping for some public comments, from people in our town
Mhm.
to help us determine whether this, I am more interested in monitoring than I am, because we don't really, in the town of Great Barrington, we don't have a good monitoring system. The DPH come out, they do a couple samples, a couple times a year, that's about it. But we don't, our town, that we don't really know what our population is, and I feel that we should get more data. Does that make sense?
I think it does,
I don't think people like to use any pesticides
right?
in our environment. And I personally feel the same way. However, there is no monitoring system for us
Right.
at this point. We don't really have any way of knowing that pond right next to our ball field contains West Nile. And therefore, we have no way of saying to the kids that are playing there, or the elderly that are sitting there watching the games, hey, you guys need to be careful.
Yeah.
Do you see what I'm saying? We
Yes.
don't have any data, we don't have any information.
Yeah.
And if we don't have information, how do we warn people?
Right. And the other part of that is when you say, I mean, different individuals have different levels of sensitivity to the use of pesticides and different factors, but that's the town's decision.
Right.
And I'm, more than willing to go with the town's decision. I would make recommendations. But if, in terms of,
So if we
I
say,
think the threshold would change depending on what the risk was, right?
exactly,
I mean, if you had high risk, I don't think I think your perception of different factors would be different.
right,
Yeah.
and that's what we're trying to do is gather data. I need the data to determine what is moderate risk.
Yeah.
What is it, how does it apply to our town? And what kind of warning are we supposed to be giving to the people that are exposed to this population of mosquitoes?
Mhm.
If we don't have the data, how do we warn people?
Right.
And would your service be able to give us input on data without spraying?
I would, so if you were to sign up, I would basically set a baseline of services, which
Mhm.
would include all the things we do.
Yeah.
But your decision would determine if you didn't want to do larviciding, you could say, but if it got to the point where you did want to do larviciding, I have to have the resources to go do that. And the same goes with adult control. I have to have a baseline to work from.
Yeah.
But if you didn't want to use adult control and you wanted to do community outreach, we could do that. I mean, we could put our resources toward that
Yes,
in that case,
yes.
and that would be your decision, not mine.
Okay.
Yeah.
Do you have other towns that would ask for those services as opposed to spraying?
It's a strange, it's a strange, phenomenon. But I mean, just our free conversation here doesn't happen a lot.
Mhm.
Towns come to me with they've already talked about it among themselves, and they come to me with, a crisis or whatever,
Mhm.
but as the season develops,
Mhm.
there can be free communication between us, and, we can cross each bridge as we come to it. Any town can call us anytime,
Mhm.
and, as long as it's the authority that's our point of contact for that town,
Mhm.
you can't have different, people. I mean, you have to have a designated point of
Right.
contact,
Right.
but that entity would represent the town,
Mhm.
and I am providing a service for the town, so they could direct it, any town could direct it. Yeah.
And you would give us a cost of what
Yeah.
that would be.
Yeah.
I see.
I mean, it is, so when they set state aid at the beginning of the year,
Mhm.
they already know what our combined budgets are gonna be for the state.
So we can't just call you on a fly and say, hey, we need you to assess this pool
Right.
and that pool and.
Well, that's right, and that's the other thing that, we have, it's built into our enabling legislation that if a town joins, the initial period is 5 years. And then they can decide after those 5 years, yes or no. But
Mhm.
those 5 years are designed so a town wouldn't jump in and then jump out. Because we have to make an investment to take the town on.
I see.
It's staff and equipment and, all those things. So there is a commitment, an initial commitment of 5 years.
Do you have a standard, like a document of agreement that, that you would use, and we can check off what we want and what we don't want? It's like McDonald's.
I know, well, that they call that à la carte mosquito control, but, we don't really do that because, we have to be prepared for the contingency of the town saying, we've got a situation where we have to go to, this level.
Uh-huh.
So we have to provide some capacity to do that.
Okay.
So, I mean, over time,
Mhm.
if a town doesn't want to spray mosquitoes, that'll reflect in our overall budget. Because we just won't be, we aren't gonna buy product and equipment if we aren't gonna be using it.
Mhm.
So that will reflect over, future budgets.
Mhm.
But, initially, until we have an answer of how things are going,
Mhm.
we would have to have the capacity to provide full service.
I see. Because right now the town is like, I don't wanna know. I don't wanna know what's out there,
Right.
and I don't wanna spray. So if I don't know what's out there, I don't have to worry about spraying.
Well, we saw that in the early days, when we first started finding West Nile in some towns. It would be a half a mile away, and the town next door would say, well, we don't have it. But they probably did. But they did, right, they didn't wanna know, I guess. But we have found it, every town we've looked, we found it at some point.
Mhm.
Some years we found it in all the towns at the same time, so it's
Mhm.
like different years at different levels.
Okay.
Yeah.
I'm pretty set.
Okay, just a moment, yes. So on our agenda, we have a discussion and a vote. I don't know as if we'll vote tonight, but are we open to hearing some comments? There's people who would like to address the issue.
I have two emails from residents. I don't know if you want me to read them into the record. I know you both have seen them. I think you addressed all of the
Mhm.
questions that were in these emails. I can put them in the meeting packet if anybody wants to. But there are two members of the Agricultural Commission who have raised concerns about pollinators, and what applying pesticides would do to pollinators. But
Should
like
like-
I said, I think Ruby has addressed those concerns.
Okay,
And just for instructions on potentially how to move forward, I think there are some people that would have been here or they might have been here if we were gonna recommend to the select board. So I wouldn't advise making a recommendation at this point, but
Yes.
you can decide how to vote if you wanna move forward or not.
well, I would say that we should keep this as a discussion topic for next meeting, but there are some people here who would like to speak on it. So if we can keep comments briefly, we can move through the agenda. So we've got some people here in the room. And we have a number of hands up online. We'll start with some of the people here in the room.
Hi, I'm Donna Jacobs, 260 Park Street, here in Great Barrington. Thank you so much for the presentation. I think the data collection is really a very, very good point, and we're talking about the level of surveillance to see the numbers of mosquitoes and whether they're carrying any kind of viruses. And the CDC has a lot of information about how to collect the data, but then we might want to engage a professional like the gentleman here tonight. And I think the data collection and perhaps researching some of the site on the CDC, which is what I've been doing just now. The reason I'm interested in this is because we're very concerned about contaminants in our water supply. And this is very much related. In fact, the mosquito control came up when I was actually reading a letter from the Department of Environmental Protection on water safety. So I'm here for water safety tonight, but hello, you're talking about mosquitoes and not spraying over bodies of water, and protecting beehives as recommended by the CDC and other pollinators that have to be protected if we found virus and decided to go ahead with a treatment. That's my comment.
Okay, thank you. In the back. Oh,
Just on that point, I think surveillance is really important because once we know that there's West Nile in our community, more practitioners would be looking out for it. And at the same time, they would test you for it. So that in those cases where the patient may not have COVID, may not have the flu, but have something, they will send out the blood to test for it. And to determine if we do actually have cases here. So a practitioner is not going to order tests on every possible known thing that could cause a fever in a person. But if they know, oh, this is tick season and we definitely need to check for tick-borne diseases, we would do that. Does that make sense? So gathering data is a way to protect our citizens.
To answer your question, yes, it does make sense, except I've been bitten by so many ticks and told, go home and be okay. So I haven't been tested for tick-borne diseases. I just take Doxy every, a couple of doses of Doxy every time I come home with a tick bite. Yeah.
That is a
Yeah, so,
recommendation.
yeah, it's hard to practice medicine, in an environment like this with all kinds of bugs.
Right.
Yeah.
Okay.
thank you.
Randy Jordan, 55 Blue Hill Road. So I'm here for something else, but this is, I have two questions. One is, do you know how bats eat? Bats are already endangered and much less of a population, and they eat bugs at night. They survive by doing that. So I'm wondering, what kind of studies, and we need them as part of our environment, what kind of studies have been done with this product, because the bats would be eating these. So that's just one thing, like how do we know how that's affecting that animal? And I'm wondering, can we find out about the effects of West Nile just by asking the doctors around here and DMC and Fairview, have people come in with any of these things? Is this even affecting our population? And how is it affecting our population? Is it significant? And because, maybe it's very significant and maybe it's not, like that would be, how does that fit into data collection? Just really boots on the ground, what are we seeing in our clinics? So I'm just putting that out as a question, instead of, you know, sampling mosquitoes.
I could answer some of that. As you well know, if a person comes in with fever, joint pains, muscle aches, that type of symptoms, it could be a number. Immediately in my head, I would, tick off quite a few different things to think about, and then I hone in down on what it could be. Where's your exposure? Were you out in the field? Were you, no, this kid never goes outside, is never outdoors, and we have screens, we don't really, so then you go into details of the exposure history. When you have an exposure history that is suggestive of something that is quite different than your standard flu or your standard coronavirus, typical coronavirus, you kind of have to look further on. And that's when you start ticking off, oh, he's been out camping and there's been tons of mosquitoes and he's in an area that's called moderate to high risk. But we don't really know whether we have it here. He's been camping out. So how does a practitioner get that information? You don't have any database to go by. And most insurance company is going to come back to you and say, hey, doctor, why are you ordering West Nile virus on everybody that comes in with a fever? You don't have any data that suggests it. Does that make sense to you?
Yeah, so you as a doctor need more information to be able to be able to assess the situation.
And therefore, we would be able to give out more warnings. Watch out. The mosquitoes lately, we've had a couple cases of this, general body aches, fevers, not to the point of, meningitis or encephalitis, but to the point where we need to really, warn people to say, hey, watch out. You really shouldn't be out without any kind of protection in at dusk.
And in my experience, the level of the virus is so different year to year. The information, I think, has to be like real time. It has to be weekly in order to make it significant. Because for instance, we've had years where we had one isolation, and we've had years where we had 60 isolation. And that's a much higher level
Exactly.
of presence in the environment.
And unless the practitioner understands what the local population is, there's no way they can understand when I should be testing for this and how to warn people.
Okay, thank you. We'll hear from Vivian Orlowski, who is the Agriculture Commission Chair. Next. We're getting you promoted, Vivian. Just bear with us for a moment. Oh, there you go. You just need to unmute yourself and you're.
Okay, now can you hear me?
We can.
Oh, great. Well, I sent an email letter to you all late this afternoon. I'm sorry for the delay. I didn't realize that this would be a major topic this evening. But one of the things that I mentioned I would like to emphasize, which is Senator Joe Comerford, who lives in the Western Mass region. She's in the Pioneer Valley and represents many of the counties adjacent to Berkshire County. She's the former chair of the Joint Committee on Public Health in the Senate. And so she has familiarity with that field besides having a background as a social worker, which is not the same as medicine, but it is related to public health care. And she is the sponsor of legislation called an Act in establishing an ecologically based mosquito management program in the Commonwealth to protect public health, because even though we're concerned about pollinators as part of the environment, we're concerned about people as part of the environment too. And Senator Comerford and her other supporters in the Senate and in the House are proposing legislation that would replace Chapter 252 of the general laws, which currently govern and create the framework within which all these county-based mosquito control groups, like here in Berkshire County, are functioning. This is their guiding framework from the state level. And those who seek to replace it are replacing it because their goal is to, just a minute, let me just read very briefly, is called ecologically based mosquito management, which seeks maximum use of naturally occurring mosquito controls, including weather, disease agents, predators, and parasitoids. And in addition, it utilizes various biological and physical controls and habit modification techniques. Under ecologically based mosquito management, chemical controls are imposed as a last resort and only as required to keep a pest from surpassing tolerable population levels predetermined from accurate assessments of the ecological, public health, and economic costs of control measures. So I would hope that concern from Dr. Chang and from the entire Board of Health would be expressed by urging our state legislators, who may not have heard about the importance of this legislation yet, to support it and to help get such legislation passed to give local groups, like here in Berkshire County, the Berkshire Control Group, they call some the Mosquito Control Project, to give them better guidelines that would emphasize more emphasis on what Dr. Chang is talking about, getting information, than on resorting to spraying as sort of an old previous view before more research has come out showing that there are human health effects. Dr. Breeder Lundberg gave a talk to legislators last year in which she talked about human health effects of mosquito control, that it's often a neurotoxicant, it affects heart disease, these are endocrine disruptors, they're related to cancer problems, they have cognitive and behavioral effects, and are especially harmful to kids. So that concern is what Dr. Sarah Evans, a professor of environmental health and children's health at the what's her full title? She's assistant professor at the Department of Environmental Medicine and Public Health at the Icahn School of Medicine at Mount Sinai in New York. And the Agricultural Commission reached out, and we're very pleased and appreciative that the Board of Health has agreed to co-sponsor her giving a webinar to educate people about the dangers of various pesticides, including she has a section on mosquito control. And she is going to be explaining why there are public health beyond pollinators about community pesticide spraying, and suggest the importance of putting our public health emphasis on public education. And we're pleased that Superintendent Peter Dillon has agreed to publicize this to the school committee and to families who are in the Berkshire Hills Regional School District, because he agrees that there's there's really no substitute for empowering individuals and families to protect themselves, because the head of a group called the what is it called? The Public Employees for Environmental Responsibility, PEER. She's a PhD and executive director, and she talked about how the connection between taking chemical action through various pesticides and even through biological controls, which affect dragonflies, which then we lose them because they are a natural way of controlling larvicide. But she talks about a lot of things, and she says the proportion of action on this to the actual protection of individuals, families, children is really very small, and the essence is on educational outreach to the community and through the schools. So I ask you to look at my more articulate email, which I talk about some of these. I didn't mention Dr. Senator Comerford's background in dealing with public health and her commitment, and also her familiarity with this region in general. But I ask you to look at that, and I ask you to take action to present our local efforts. And I appreciate that the Berkshire Control District is trying to control things locally, but they need better guidance that's up to date on research showing the harm of a lot of these measures to people as well as to pollinators. Thank you.
Thank you, Vivian. Christina Kurzika, if I have that right. Please forgive me if that's a mispronunciation. You're next. We'll promote you to just a moment.
Hi, can you hear me?
Yes, we can.
My name is Christina Kuzica, and I am also a member of Agricultural Committee. And I just wanted to bring to attention a couple more things. I think Vivian covered a lot in terms of health. In terms of pollinators, we were told that the problem was addressed, but I don't think people realize that lots of pollinators are as small, maybe not as small, but almost as small as mosquitoes. So some of the wild bees are really tiny. And so the amount, as we were told, that they are adjusted to the size is not going to protect them. The other thing that I want to talk about is people growing organic food in areas that is being sprayed by pesticides, whether they want it or not. I think it's kind of ironic. And the most important for me in the moment is a problem with the dogs. Dogs walk sometimes 3 to 5 miles a day with the nose to the ground, and they are going to be definitely affected. And if children and adults are affected, the dogs would be tragically affected. Thank you very much.
Great, thank you. Next on the list is Kathy and Kevin Regan. I'll assume it's Kathy unless I hear otherwise. We'll have you promoted in just a moment. All right,
Hello.
Kathy. Hey, good
Hear
evening. Yes, we can.
I'm going to speak first, and then Kevin wants to have his time as a separate, person. So I just wanted to bring up, I understand wanting to look to see if there's, a sampling to check out what's happening with mosquitoes. But I am concerned that if West Nile is found, that things are going to escalate from there very quickly. So I think we need to put things in perspective, and we can't let fear overtake logic, which I think has happened quite a bit, especially in the last few years with the medical community. You know, one thing that I see happen is that the studies that come out showing that pesticides are safe, you know, when used in certain amounts, nobody, especially the medical community, doesn't take the time to see who funded those studies. And I think that's extremely important. Let's take that extra step. When you find out who's funded the studies, very often it's a company that's benefiting by the profit of sales, whether it's chemical sales or manufacture in some way. So I'm not at all comfortable. I've heard stories from my vet about dogs having a higher rate of Hodgkin's disease, as the woman that previously spoke, being due to pesticides being on the ground. They get Hodgkin's just like people do. And as Vivian said before, I think that the impact to children playing on grass, to people is very, very important, and people are not looking into that enough. When I was in Stockbridge years ago, I got right behind Stockbridge, by the way, is pulled out of the mosquito control project. So it'd be very interesting to see why they did. You know, if another town is considering using their services, it'd be good to find out from them why they're not using their services any longer. But when we were in Stockbridge years ago, we were behind one of the mosquito control trucks, and they were legally supposed to shut off their spraying when there's any vehicle around them. And they didn't. We were directly behind it. We didn't know what they were. We found out later. And we really got a lungful of horrible smelling chemicals at that time. So that was a great concern. So we know for a fact that the chemicals are toxic. I, for one, just don't want to be exposed to them. I think that there's very few people, as I said, Ruby brought this up before, and it's an important point. Most people that are exposed to West Nile don't get sick. So I'm not concerned if there's people that aren't exhibiting symptoms, but they technically have West Nile in their body. That just shows a well-working immune system. Only 1% of people show any kind of severe illness with West Nile. So things can get out of hand very quickly. And I think that the cure can be worse than, the fact that we have a 1% risk. So that's all I want to say. And I'll hand it over to Kevin.
All right, thank you.
Hello. A couple of things. You said the ingredients break down. Is that just means they're separate components, or they disappear? I mean, they're still there. What does that mean? Also, you said that they spray dusk to dawn because the mosquitoes are out at night. But then there's also confused because the insecticides last a day. So if they're lasting a day after that dawn spraying, that means the pollinators and all the daytime insects are exposed to it, I would assume. Other stuff, you said larvae treatment where you can get to it, if there's your cattails and other stuff where you can't reach, I assume you spray. And the spray only goes to 300 feet. So what happens beyond that? Something else, residents can opt out, but what about drift from neighbors or areas that spray? You said that if you find a hot spot, you'll spray a 1 mile radius. What if you opt out within that 1 mile radius? Do you check for people that opt out within that 1 mile radius? And in conclusion, I'd like to say that we got to go along with the risk-benefit ratio, cautionary principles here. And also, everybody got to remember that the captured government agencies like the FDA and EPA also approve DDT. So there you go. Thank you very much.
All right, thank you, sir. We'll hear from one more, who is Matthew O'Brien. And Chris, if you wish to address those, you can. You're not certainly.
Well, I'm glad that that last speaker was listening closely.
Yes.
He had all the details.
Yeah.
But so when we say the product is breaking down within a day's time, there's two things that break it down. One is contact with water, and the other is sunlight. The components it's going to break down into are going to be CO2 and water. And what was the other issue?
Drift.
So our alarm system in our truck is going to be at the effective range of the equipment. So when we have a property line come up, the range at which the thing would be activated would be 300 feet, the effective range of the equipment. So there'll be a 300-foot buffer between the property and where we would turn around. That's, that's what we can do.
Okay,
The product, if we are gonna spray mosquitoes, that's how the mosquitoes are killed, by the product moving through the environment, so.
I see. Okay, thank you. Matthew, you just need to unmute and you can address the board.
Hello, thanks for the opportunity. I have a fundamental question. Can you hear me?
Yes, could you just state your name and address, please, for the record?
Matthew O'Brien, 33 Van Duzenville Road.
Yes, thank you.
I had just had a fundamental question. Now, as with just the idea of the virus itself. Now, as like with the PCR test that we found later, the CDC they would dial it up to get higher results when there really was no disease present, but it was, detecting it. I agree with the doctor that the data is very important, but the testing, do we know how that's tested, how accurate that is? And that goes for either, the mosquitoes themselves or the larvae, or even the people later that get tested to see if they have it. Now, after what we saw with the PCR test, and even the inventor of the PCR test, Kari Mullis, saying that you cannot use that test for diagnosis at all. Some of the fundamental things have, what we're talking about, science has certainly, there's some big questions there. So, getting accurate data of tests that actually can detect something and identify it accurately, that seems to be one of the problems. And I would suggest for anybody that would want to look into viruses, Louis Pasteur, his papers were finally released, and Gerald Geeson at Princeton University wrote a book called The Private Science of Louis Pasteur. And if you want to start to look at the fundamentals of what we're talking about with the viruses and how this all, came about. And we also have like the woman was saying earlier, we have all these corporations that make tests, people that do the testing. We have and they're all corporations that are, that have systems that are just cranking away. And when you have an inaccurate PCR test, or you have some kind of testing that's not right away, your data is skewed and you're spraying and doing all kinds of stuff when, we're not seeing what it is, or even diagnosing people with a West Nile virus or a tick-borne disease. I think those fundamentals, if we could look at, might help a lot. Thank you so much.
Great, thank you. Would you like to address any of those questions, comments?
I don't have any comments.
Okay.
One thing I would
Yes,
just say about that is, in this case, I think it's a function of government. So that I'm a government employee, the mosquitoes are going to the state virology lab, and then the results are going to come back to the local board of health. So we're not for profit and generally shouldn't have an axe to grind. So, I mean, we're looking for the truth and the accurate data. I think that's where I would say we're coming from.
Okay. Great. Well, I see one more hand up. And we'll just. Matt, if we can take any more comments, we'll have citizen speak time at the end. We've been going almost an hour and a half with Chris, so we'd just like to wrap that up, but we can certainly take any more questions shortly at the end of the meeting. Any final thoughts from the board?
No.
Okay, well, it's my feeling that we should continue with this on our next agenda as a topic for further discussion. We all have some things to think on. Sounds like from the discussion tonight that we're more interested in surveillance for our
Right.
town.
Right.
And so maybe we can do some work between now and the next meeting on what that would look like for cost and
All right.
and take it from there.
Yeah, I
Great.
think it's
Sounds
just really frustrating when you see the data come back from the state saying that we're at moderate risk, and, as the Board of Health, you just don't really know what to
Yeah.
do about that.
Well, the way that you got the moderate risk level was your proximity to the towns where they had data. So,
Exactly.
yeah.
So we're kind of going off the goodwill of the people around us that do pay for your services to gather the data. But we don't really know in our town, what is that data? And why does it matter if it's just a mild disease? The reason it matters is because we would have better ability to say, the levels are getting a little higher, maybe we should take more precautions, maybe we need to have more long sleeve clothing when we go out at night. You know, all of those precautions that doesn't cost anything, that can be done easily, can be given to the citizens so they are aware why we're doing that. That's the whole point. The point is prevention. It's not to diagnose disease and then what can we do about it? That's not the point.
Great. Okay, thanks, Chris.
All right, thank you for the invite.
Thank you so much
Pleasure.
for coming.
Yeah,
Yep, you're welcome.
safe drive back. You're in Pittsfield or are you?
Pittsfield, yeah.
Pittsfield, okay, it's not too.
And if you need anything, just berkshireMosquito.org.
Great.
You can contact me.
Great.
Thank you. Rebecca.
Thank you very much. Okay, the next item of business is a update on the Southern Berkshire Public Health Collaborative Fall Vaccination Clinics. And any discussion. Now, I'd like to just make a quick comment that after receiving many admonishments, stern admonishments about lack of specificity on this agenda item, as a bit of an aside, I had wanted to make some comments, but after consulting with the Division of Open Government, it seems that we need to have to supply that specificity in order to have that discussion. So I apologize for any confusion, but there'll be no vote tonight. And any discussion on this agenda item will be in relation to any questions for Mr. Willits from the board. After which, of course, any participant is free to address the board on this topic or any topic. So without further ado, I know Mr. Willits is here. Thank you, Jim, for coming and for bearing with us. It's amazing how some topics can they can take some time, as I'm sure you know.
They always do. Well,
Yes.
I sent an email off to Rebecca this morning about, I don't know if you had specific questions on our clinics, but you know, we're about 3/4 of the way through the clinics, well attended. Staff's working a lot of hours. You know, I think overall the clinics are going well. You know, we are struggling a little bit with volunteers on some of the larger clinics. You know, we have enough staff for that are nurses. We have per diem staff. Jane and Jill are basically working 20-hour days. They had another clinic today. We have a couple large ones left, and some smaller ones over the next couple weeks. We're offering the flu, the high dose, the egg-free. In the COVID, we're about $100,000 into vaccine purchase between flu and COVID. COVID's very expensive. And I think overall it's going really, really well. You know, I think at the end of the clinic, we'll try to pull a bunch of demographic information on age, population, location. And then I'll also confer with Laura because, you know, because we only cover data on our clinics, and I'll consult with Laura to try to get a bigger Berkshire County picture on what our demographics look like. And then we'll fold that in together. Then we'll be able to see what that looks like. We may hold one more large weekend clinic, maybe before Christmas, just to see if we've missed anybody. But so far, so good. People are pre-registering. The flow's going really well. The locations are really well for the most part. A couple of small towns are challenging with locations and spots, but we're getting a lot of demand for our vaccination clinics.
How would you say it compares to last year in terms of the demand for, say, flu or COVID vaccines?
Yeah, it'll be interesting to see what the numbers look like. I think the flu demand is about the same. You know, when we met at the collaborative meeting, when we were going over the private purchase, COVID, we were concerned of the cost of the COVID and maybe buying too much. So we're through our vendor, we're able to buy small batches, and they're coming in and out very quickly. We just put another order in for 200 more COVID, and we expect that will be gone in the next couple of weeks. Hard to say. I think last year coming out of the gate was our first year doing it, but it's very well attended, and we're being asked to hold more clinics rather than less, actually. But we'll see. We'll have to see how that goes.
More clinics for both, or more clinics for?
More clinics for both. Yeah, more. We're being asked to possibly to do more, and so we're gonna get through the next couple weeks of our scheduled clinics, and we're gonna probably hold one more maybe at the end of the calendar year, like on a weekend, so it's more accessible for everybody to come to.
I see.
To give people another opportunity to come. I think some of the feedback we're getting, people enjoy our clinics. They're accessible, they're easier to get to, especially the seniors. Seniors do go to the school clinics. It's not just the staff and the kids. It's being able to be accessible from a public health equity perspective to make sure that people are getting access to whatever vaccine that they choose to get.
I see. Okay. I had one question, more of a general regulatory question. Since the COVID vaccines have been EUA approved, and yet there's been no declaration of emergency, how does that work in terms legally? How does that work? I mean, I'm imagining it must somehow. I haven't heard that described by anyone. I was just curious how that can happen. My understanding had always been EUAs for, granted for distribution during stated emergencies. So I was just curious, since we don't have one, to my knowledge, how can we distribute those vaccines at our clinics?
Well,
when they have.
Well, what I know is the vaccines are approved for the public health to offer them at our clinics. Anything outside of that is beyond my pay grade.
Okay. Do you know anyone who we could address that question to? I mean, it's just more of a kind of a.
I can tell you why.
Okay.
So September 12th, the ACIP, which is the Advisory Council for Immunization, which is a external group of physicians that deal with vaccinations, and they're appointed. So they go through all of the vaccines that are approved, not just COVID, but all of the vaccines that are approved. And they add, subtract, add additional vaccines, give increased recommendations, and it's a 6-hour long kind of back and forth discussion. And at the end is that they come to a conclusion with a schedule and a list of the vaccines that are approved for distribution, and they give the recommendation of who to give it to, age group, how to give it, and what kind of precautions.
Yeah.
So this happens every year. And so as primary care doctors, we go by the new guidelines every year. Every year we come up with ACIP recommended. So this is something that's passed down from the CDC, and then we have directions on how to provide the vaccine.
Right. I guess my question more is how can you provide an emergency use product when no emergency has been declared? It just sounds funny to me.
It's no longer an emergency product.
But it was approved for emergency use. It didn't get full approval.
It's not an emergency vaccine at this point.
Right, but it was approved for emergency use. Or am I missing something?
Yes, you are missing.
What am I missing?
You're missing the fact that now it's an approved vaccine.
But
it's no longer an emergency vaccine.
But it was approved under emergency use. Is that just semantics?
No, it was approved as an emergency vaccine, but now it's not.
Well, this latest updated the monovalent COVID shot.
Mm-hmm.
My understanding from press releases that was granted approval under emergency use.
No, I don't think so. I think they've done enough data studies and now it's approved. It's
fully
no longer by the ACIP, yeah.
I thought the ACIP recommended that it made recommendations and the CDC took those, but I thought it was granted emergency use approval. I'm just curious that it's a legal thing, and I was just curious about that question.
As far as I know, it is fully approved.
Okay.
In Dr. Chang, if I can also add too, we don't just decide to hand out vaccines. We have a medical director, Dr. Charlie Kenny, who's the collaborative's medical director that has to sign standing orders, go to clinics and supervise, and we follow all the recommendations by CDC and DPH. We don't just send staff out randomly to give vaccinations.
Sure, I'm not insinuating that at all. It was just a question generally. Because to my understanding from reading the reporting, that's.
I would like to have a point of order.
Yes, ma'am.
Because I think this discussion about the legitimacy of vaccination is beyond our scope of topic to satisfy the open meeting law. I think it's really important that we stay on topic to our agenda.
I think we are on topic. We're discussion of upcoming clinics and it's pertaining to that. It was a question. If you've answered me.
Whether it is a legality issue doesn't really pertain to our clinic.
Well, that's fine. If no one can give me an
So I
answer,
would
that's
like
fine.
to stop this process
Yes.
at this point. And if you have any other questions for Jim, please go ahead.
Well, I'm just responding to Jim. I just want to be clear that I'm
And I
not
think
insinuating any
If you
wrongdoing.
have any other questions about the clinic, feel free to ask.
Your point is well taken. Is Jim here still with us? Okay, Jim, that does it for my questions.
If you know any volunteers want to work clinics, let us know.
Okay, I'll put the word out.
Thank you, everyone.
Thank you, sir. Have a good night. With that being concluded, if there's any Board of Health questions or updates from the Board of Health itself, now's the time. I don't have anything. And Peter, I'm not seeing any waving hands, so I'm assuming there's nothing from you. Nothing from you. Okay.
I think there is some.
No, is it possible to just have a little context on this thing about clinics? Are these, I don't know who that gentleman was who reported.
Sure.
Are these paid for by the town? Is this authorized by the board? I understand there are clinics at schools offering shots. So is this something that this board has authorized?
As Jim Willits is the director of the Southern Berkshire Health Collaborative, which we are one of the member towns. We've contracted with them to provide nursing services. Part of those services is to hold flu clinics throughout the year.
Including then COVID shots.
And yes, now that they've been approved.
That's very helpful, thank you.
Yes.
Is this public comment time?
We can now move into citizen speak time. So considering the late hour, I'll just ask people to be as brief as possible, no more than 4 minutes, if possible, and we can move through any comments. There's a few hands up online. There's a few hands in the room. So we'll take you, sir. Just need your name and address.
Daniel Sites, 31 Third Street in Great Barrington. So I'm concerned that perhaps there hasn't been sufficient due diligence about sponsoring these clinics. So first of all, anytime you want to sponsor a clinic, you might want to know about a risk-benefit analysis. It's well known that children are virtually at no risk from COVID, no risk of serious ailments. However, we now know that healthy children, young adults and so forth are dropping dead of heart attacks, stroke, they're getting myocarditis and so forth. So if this is something that you're sponsoring, I would be concerned, is there possibly an issue of liability, especially if there hasn't been a careful risk-benefit analysis about this. Also, we know that the shots don't stop transmission. Originally, there was a promise that these were safe and effective meaning they stop transmission. We were told this by the CDC and many officials. Now we know that people routinely get COVID even after getting the shots and getting multiple booster shots. So again, especially with children, are we serving the children well or are we endangering the children? Does that put the town at some risk for liability? very careful analysis was done of all the death certificates between 2020 and 2022. There's a website that has this information via veravita.com. And basically, once the vaccines, the COVID shots were introduced, excess deaths went significantly up. And the deaths were not due to respiratory ailments, but they were due to things like blood clots, cardiac conditions, and so forth. And that's why we're seeing all these various strokes, heart attack, myocarditis, and so forth. So again, here's a very important risk factor. Is the town aware of this? And if they're supporting these clinics, does that put you at some liability? Pfizer itself admitted that there are over 700 side effects associated with these shots. If there's a well-known requirement that people be given informed consent, are patients being told, or parents or adults being told that there are all these risks associated with these shots? Have you really checked to make sure that informed consent is being given? If it's not, does that put the town at liability? And even if it doesn't put you at liability, let's say a healthy child dies tomorrow, right after they've gotten the shots. We're now seeing cancer going way up. We're seeing healthy athletes collapsing on the field. You can find all of these things. You can see people collapsing doing TV interviews and so forth. This is all easily accessible information. So what sort of situation does that put you in if people are harmed by these shots? Informed consent is very important. Have you looked into the fact that there are a number of European countries that have actually said young people, even adults into middle age, should not be getting these shots? That's also part of the due diligence. These European countries are not making these decisions out of the blue. They're doing this based on a review of the data. So if you're endorsing shots through funding and so forth, but there is good data that shows that the risks outweigh the benefits, again, are you putting yourself in a liability situation, and are you putting yourself in a very difficult public relations situation? Also, I think it would be helpful just from a standpoint of transparency. Is the town getting payments for pushing a certain medical procedure? We know that hospitals have been paid to push the COVID shots. We know that in the case of if there was a positive diagnosis, they got an additional payment. Use of remdesivir, they got additional payments. If people were put on ventilators, they got additional payments. I would like to know as a citizen, and I just think that would be part of this conversation, is the town getting any payments for sponsoring these, and are there conditions in terms of receipt of public health monies? Because if there is, then this is also a conflict of interest, and this compromises the situation. These decisions should be made based on solid information and so forth. And by the way, just a final note on this, and we heard, an earlier person talked about how products are often tested by the very companies that produce them. Well, Pfizer, the drug companies, were responsible for testing their own products, and they derive billions of dollars from that. Even editors of major medical journals have now said that much of scientific study cannot be trusted precisely because of these conflicts of interest. So what I would urge is there are so many questions around the efficacy and safety. This has all come out that endorsing a dangerous product, and especially one that's unnecessary for children, could really put the town at risk, put individuals at risk, put our children at risk. I think, and I think there's a potential liability as well, especially if there isn't full informed consent.
Thank you. Next. Well, Randy?
Thank you. Randy Jordan, 55 Blue Hill Road. I'm going to read this, and I hope it's coherent. And it goes along with what Dan's saying, but some of it's a little bit of a repeat. So there's ample evidence now regarding the injuries and deaths attributed to the COVID mRNA injections, and I'm directing this to the new COVID shot that's coming out. I will send you, the Board of Health, several of these reports and studies that I found really credible over the next 2 weeks to put into the public record, and also just if you could review a few of them. My concern is that people in our community, especially parents, but everyone, are not aware of any of the public side effects, possible side effects of these products. I'm a healthcare practitioner, and so I did a huge deep dive into this because I wanted to be safe for my clients, and I wanted them to be safe. So I have put countless hours of research into looking at research that isn't CDC research or FDA, it's more independent research or other countries, as Dan said. So it's things that are not as accessible to the public. So I'm just concerned that, people aren't aware before they take these shots of the possible side effects of these products. We're still being told that these products are safe and effective, and we're encouraged to get them. And I'm all for people getting shots. I just want people to be able to have good information. That's all. That's my bottom line. I have nothing against. I just want people to have the information. And I want to know, like, what is the Board of Health's role in this? So that's one of my questions. There's no product. So in the new, from what Anna and I could see, there was no, in the new Pfizer products, there's no product inserts. So there's no ingredients. There's no side effects, possible side effects. There's none in the study. So how do we even, doctors themselves have to rely on boards, but they also, I feel like we should be able to see, people should be able to see and make their own decisions and not just be relying on the government agencies. Just like Dan said, originally the public was told that these were safe and effective, that only one shot was needed. They prevented transmission, they prevented, me giving you COVID, that they reduced your chance of getting COVID, and that you'd stay out of the hospital. All these things have been proven false, and the public health agencies had to backtrack on them, but they're still saying it. It's like they backtracked, and it's all on the CDC, you can go on the website, it's all on the CDC, but they're still promoting it. So it's like a double speak for the citizens. And I'll just end by saying, like Dan said, I'm really concerned that these products have been shown to cause significant increase in, especially for younger people, pericarditis, myocarditis, all the blood clots, as well as all the other significant injuries. And these younger people are at virtually no risk of injury or death from COVID. And, if they're, so why are we even, why aren't we telling the parents this? So what I recommend is that the Board of Health, and I don't know what your purview is, so I apologize if this isn't your purview, but I just wanted to bring this because I've just been concerned about this. I don't know what your limits are, but I wanted to have a discussion about this. And I recommend that the Board of Health review these studies and at the next meeting have this as an agenda item to discuss, just giving informed consent of the risks associated with these products to our community members before they get the shot. Then we can have an educated community that can decide for themselves the risk benefits of these shots. And so I would like to know if we can have a discussion about this at the next meeting. And again, I don't know I don't know how much you guys can do about this, but that's what I'm putting out.
Thank you. Yes.
I'm here on a different topic, but related,
It's-
on one.
You can talk about whatever you please.
Oh, thank you.
You're
very
up
much.
next.
I'm Donna Jacobs, 260 Park Street here in Great Barrington, also known as Housatonic. And I'm here kind of on behalf of residents of Housatonic, Great Barrington, West Stockbridge and Stockbridge, who are all consumers of the Housatonic Waterworks water supply. And I'm asking tonight that the Board of Health address the safety of our water and advise homeowners what action needs to be taken to protect ourselves from the reoccurrence of contaminants, which are a threat to our health. The Board of Health has been oddly very quiet on this topic. In fact, I think the consumer confidence reports from the public water services are outdated. They're all 2022 and the 2021 on the website. So in terms of tracking the safety of the water and the consumer confidence reports, which is sort of a baseline document that's not even available to the public in terms of what you're all saying the status of the safety of the water is. So I'm here to really ask the board to issue statements regarding water safety and update the consumer confidence reports. And also, in keeping with the consumer confidence report, those test results are produced by Houstonic Waterworks, where we have the conflict of interest issue raised again. They're the service provider, they're the ones who make the money in delivering the utility, and they're the ones who are doing the testing. So the residents would like to see independent tests done. And I'm asking the Board of Health for your involvement and partnership with the Department of Environmental Protection to see that the testing of the water for all of our public water systems, not just Houstonic Water, but that we have regular testing so that we have confidence that the water is safe. The second thing is that, or the third actually, which is to continue in the partnership with the Department of Environmental Protection, the water project, to partner with them and ensure that all public water suppliers provide clean water to consumers. This is a quote from the June 30 letter from the Department of Environmental Protection Drinking Water Program that was sent to you all. It's a 32-page letter, and I'd like to bring your attention to part 2 of this letter. And it's about reporting emergencies. And it expects the Board of Health is going to report to the Department of Environmental Protection emergencies within 2 hours. And included in those emergencies are chemical or microbiological contaminants of the water supply in exceedance of the limits specified by the Mass DEP's Office of Research Standards.
Can I interrupt you just briefly? Is this pertaining to boards of health who oversee a public water supply?
I think that
Or
the
because,
same kind of things you all do.
no, they don't, we don't.
Then why are they sending this letter?
I think there's some confusion here because this is a privately owned water supply. We have no jurisdiction over them.
Okay, I think you might be wrong about that because, well, the reason I say that is because I've been doing a lot of research also.
Okay,
And a PWS, public water system,
yeah,
whether privately owned
yeah,
or publicly owned,
yeah.
is still eligible, or it's still required to be regulated by the Department of Environmental Protection and the water projects.
Yeah.
They're still required to report and to improve when there are water safety issues. They have to upgrade their system. They're accountable to the government.
Yeah.
And the government, and you're part of the government. And I think that unlike the select board that does say they don't have any jurisdiction over privately held utility, I think the Board of Health actually has more influence, because if you say the water is not safe and you report that to the Department of Environmental Protection, that the water is not safe, and if you're reporting, you're sending in notifications of contaminants, and also a pattern of unusual customer complaints about the water quality, such as taste, odor, etc., is an emergency that needs to be notified by the Board of Health to the Department of Environmental Protection. That's a letter that was sent to you. Now, if you want to speak to them and say, hey, fellas, we're not under your purview. We're not part of the Department of Environmental Protection. We're an independent board. We do these other things. We don't do what you expect us to do. Then I think that needs to be clarified.
Well, we've had them out and this has never come up this time.
Then why is there a 32-page letter sent to you with expectations of your functionality and partnering with the Department of Environmental Protection?
That's a good question.
It's a very good question, and it's a question that comes from a need. This community needs as much support as it can get to address a problem that's been going on for years. And I don't know if you live in Housatonic. I do.
I'm aware.
I'm
yes.
rationing water. I'm bringing it in the 4 gallons so that I have potable water. I buy it independently from the bill that I pay to Housatonic Water Works. And it's so interesting how even our select board, who's been listening to this for years, don't know what it's really like until they spend the night in a house in Housatonic serviced by Housatonic Water Works. And if you were at the DPU meeting, you heard testimony to that effect, they had no idea they couldn't turn on the tap. I wouldn't think that I'd have to ration water in Massachusetts to have potable water, but the amount of time it takes to drive, to get water, to bring it back to my home, it runs out really fast. We're paying a lot for it. We're going to be asked to pay more for it. It's not safe. Health, safety, isn't that your purview? In this community, aren't you all responsible for checking out the safety and the health safety of our environment here? We're talking about pesticides. We're talking about testing for West Nile viruses. You don't care about water?
Well, I wouldn't say we don't care.
Okay.
I think what it comes down to is in all my time on the board, no one has ever said that we have any legal jurisdiction over the water supply.
It might be worth looking into, because if you do,
Certainly, I
you
think,
could actually influence
Sure.
this situation in a positive way.
Sure.
You know, can I just correct and add in? I had spoken with the DEP multiple times. I had requested for them to come to give us a discussion at a Board of Health meeting. I think we did that.
we did, they came.
Yeah, we did that. So we have been reaching out to the DEP, and we had requested they come and talk.
I know they're coming at your dinner to talk about.
No, this is
that-
different. They
that's-
came to
Yeah,
one.
but the DEP is a very big organization.
They came, their
with-
representatives.
No.
You're talking about the water project.
Susan Wade has nothing to do with water. She has to do with solid waste in
Yeah, I
Western
understood that.
Massachusetts.
But
Yeah.
so DEP has many different areas of responsibility.
I have contacted the DEP multiple times in the water department. What's her name?
Deirdre
Deirdre.
Doherty.
Deirdre Doherty. And we had multiple discussions over the quality of the water, the level of the haloacetic acid, the amount of manganese. I have done all that. We had them come via Zoom to give a talk about what their jurisdiction is, how are they gonna move ahead, and answer any questions that people have had.
All right.
So I can't say that we have not reached out to the DEP.
So you've given them notifications of the emergency situation in our community.
They're quite aware of it.
They're aware
If
of it,
you
but
look
have they
at-
been officially notified by this board? Have letters gone to them saying we are in crisis here?
The problem is that we don't get the water testing data until quite a bit later. So
Then
we
that's
don't
what we're
have,
asking you to
we-
do.
we
is
don't
to
have
find
access.
Avenues to test the water more frequently, independently from the utility itself.
that requires quite a bit of funding. And I'm not quite sure we have, our department has the funding to be able to
Well, we
go
could
out.
find out if there is funding available for testing, and I do believe there is funding available for testing. through
I'm
the
not
state
aware of any funding from our
For
board.
testing water.
Right.
Yes, I think funds are available. They need to be applied for. We can get the funding, we can test the water.
Where do you go to get funding?
You
Actually,
go onto the internet and you look for funding for upgrades in water delivery systems, infrastructure. And they have, everything from how to teach you how to run a company, to testing the water, to rebuilding the infrastructure. There are low-cost loans and there are grants. Blandford just got $1,000,000 some hundred thousands of dollars because they applied, and it was granted to them in September 5th. We're not doing anything to get the
So-
money
so
to
that-
improve the situation
so
or
the-
exercise any
Right.
kind of influence on a dire situation.
so those grants are written by the town. They're not written by the Board of Health. So the town has
Who in the town writes grants? That's my
Chris
question.
Rambo.
And why aren't we writing grants for improving the infrastructure of our water delivery
I
system?
think you should ask him.
I don't know who it is. Who is it?
Chris Rumble, the assistant town planner.
Yeah.
he works,
Would you
not-
ask him too?
He's
Because
not
he
the town
doesn't know
grant
me.
writer, he's the
and-
town planner.
but,
He's not the town grant writer.
Oh.
He can write grants for planning,
Yeah.
but he's not the town grant writer.
Who-
Just,
So who does that?
it depends on the department. We can all write our own grants.
So if you give us information on how we can get grants for water testing.
Is that
I
my
would
job?
do
so there's two
I
things.
mean, you're my representative,
I am-
and I'm wondering, what are you doing for us?
We understand
Okay.
there's this grant writing, grant application thing, but I do think it comes down to a regulatory position. From a regulatory standpoint, I don't think that we have the jurisdiction
No,
to do
I
that.
really-
It's a good question.
Well, it does kind of suggest in this letter, if you take.
But letters are one thing, but the regulatory statute is what needs to be cited that says you have this.
seen Any evidence that we have jurisdiction over that private water? Can you
It
give
depends
us
on what you mean by
evidence?
jurisdiction. You report them, and they have to show what they
No.
are I'm sorry, it's written here. They have to report what they are doing to correct the problems.
That's
So
what the
you have
DEP
looked
does.
at There's a problem, and now there's oversight.
But this is what the DEP does. They do this. They get the testing.
But the DEP is asking for your partnership, and I'm asking for your representation.
They've never done that.
I'm sorry?
They've never asked for our partnership.
It's in this letter. We are asking you to partner with us. Nobody's read this, have you?
I've never
So-
seen it come through
I
official
sent it
channels.
to you.
I've never received
Because
it.
your email address went somewhere, I don't know where. I was here at the last meeting.
Yeah.
And I referred to this letter, and you all didn't know a thing about it, and it's addressed to you.
But it's never come through the official channels that when we deal with the DEP, though, like the,
You know what? I don't know what to say to you all.
yes.
You're really letting down this community. And I want to bring that to your attention, that if you're gonna refuse to help us
We're not
with
refusing.
a health issue,
We're not
there's something
refusing.
very wrong with this picture.
Okay,
No.
just so we're clear, we're not refusing. We've
There's
never
a lot of
refused.
pushback here.
We're not giving you pushback. We're giving you explanation.
I don't agree.
Oh, that's
These
fine.
are not explanations, these are confusions.
That, I agree.
Nobody knows the answers. Research is required.
We
on
agree.
Both ends.
Yes.
I've been doing tons of research.
Okay.
I don't see you all doing a whole lot of research on this water situation or coming through to our community, except for Consumer Confidence Report dated 2021 on your pages on the town website. Is that the best you can do?
We will look into this
Can
further.
I I do the research. I go to Zoom meetings. I actually went to one recently from Boston Children's. And they had someone that talked about private wells and we discussed manganese levels and what they are. They now have set levels for children. So we are doing our due diligence. I have reached out to the DEP. We have had multiple conversations with the people there. And they have told us over the years that we don't have jurisdiction over the private sources and they're going to be dealing with it.
You may not have jurisdiction, but I think you have influence.
I don't think we have
You
any
have
influence
because
No,
the
because-
utility,
because we have had multiple conversations with
all right,
them.
so the utility.
So you could look on our website and you can look up our meeting minutes. And there will be minutes where there had been discussion.
BOHs should be aware of the provisions of the Water Management Act for water supply emergencies. A
Right.
declaration of water supply emergency requires the public water system to submit a plan to remediate the emergency. That is influence.
Right.
You've
So
got
for-
them to submit a plan for remediation. You've just influenced the situation.
Right.
They have to be transparent.
so the-
They can't hide behind their corporation.
The situation,
Plans can include measures to purchase water from other suppliers, use emergency resources, implement aggressive conservation measures, and provide mechanism to restrict outdoor water use for those PWSs that do not. They even say in this letter that the PWS should provide relief to its customers, and supply water from other
Public water
sources.
supply.
oh,
Okay, I think in the,
I did not mean to go on this.
I
long.
understand.
I'm in shock that you all are telling me that there's nothing you can do.
we're not saying that. We're not,
To hear some kind of saying what you want.
we're saying our working understanding, and I would like to move on. There's a few people who've been waiting to
All right,
talk.
I think-
Are saying our
You know
working,
what? We're a lot of people now. We're over 250 people who care about this, who showed up at a DPU meeting last Tuesday.
yes,
We're getting some press coverage.
yes.
Okay, we need our select board to be behind us. They showed up. we need our Board of Health to be behind us. I'd like to hear how you're all gonna show up,
Okay,
because
well,
that's what we need. If you're gonna represent us on a Board of Health, our health is in your hands.
point well
If
taken.
Thank you very much.
Right. Thank you. Okay. In order,
Did you come to our meeting at the DEP that when they cleaned?
I spoke there.
No, they came to one of our board meetings. I
The
had
only
arranged
board
for
meeting I was
that.
at was the last one I was here when I brought up this letter and you asked me to forward it to
No,
you.
this was been a year.
Yeah.
No, this is my second meeting.
Yeah.
Okay, so you have to realize that we have been doing this for quite a while.
Nobody knows you have,
well,
and
that's,
nobody feels supported by our Board of Health.
Well,
So I'm letting you all know, you want us to feel supported by you, there's a way of communicating with us.
okay,
right, but
Thank you.
okay.
please look at our previous minutes. Okay, over the years. We had Housatonic Waterworks on our agenda for many.
I don't know what's happened to it since, it wasn't here last month.
Yeah, you
And we
should,
we're in a crisis now.
yeah, please review all of our,
I'll review all the minutes,
Please
but
review
if
our
I'm gonna do
minutes
that, it's gotta be two-way street.
and really try not to accuse us of things unless you've
You
reviewed
know,
what
I've
we've
been
done.
triggered by I can't do anything for you attitude. We can't do this, we don't have jurisdiction, we've done everything we can, you may not know what it is, but we've done it. That's not helpful. And we're angry in this time because it's been going on for too long. We try not to get emotional, we try to stick to the facts, we try to be intelligent and do our research and find the avenues to find the solutions. And we're asking you, help us solve the problem.
Have you reached out to the DEP?
Yes.
And what did they say about jurisdiction?
You wanna do this now? You wanna have this conversation now? I think we're out of order.
No,
No, I was
we,
just asking,
Do you really,
because you're saying that we.
we have to call in Kathy Regan, who has been in touch with the DEP and the DPU.
Uh-huh,
And get information from other people who are contacting people around the state and other communities.
so I would ask one thing. If you show me the regulatory statute that gives us the authority, and we are more than willing
yes.
to do what we can do, but I need to see the regulatory statute. I haven't seen it. It's, now it may exist.
To look for.
I believe we
Why
have.
don't you find out?
We have talked to other people in the state. We've talked to other people. No one has provided
I'm
that.
being told, Donna Jacobs, go solve your own problem.
No, we're
Yeah,
not
that's
telling you
what
that.
I'm hearing from this board.
Well, we didn't
Go
say those,
solve your own
we
problem.
certainly didn't say those words.
Well, you didn't say those words, but that's the message that's being delivered here tonight. We're on camera, you've got media listening to this meeting.
Yes,
They're gonna have a field day. They love controversy.
okay,
All right, I'm gonna say goodnight. It's been a long night.
sure. Thank you for coming.
Thank you.
Cardinal, we have next. And then she had his hand up for quite some time.
I think I
Yep.
already promoted you,
Oh.
Cardinal. I guess not.
No, it's just the two guys. Okay, Cardinal, you're promoted as a panelist. You just need to unmute and you can talk.
Okay, did I do that right? Can you hear me?
We can.
Okay. So going back about 15 minutes.
If we could just have your name and address for the record. and-
Cardinal Montano High Street, Housatonic.
Thank you. And if we could keep it as succinct as possible.
Oh, I
we're-
will. I will.
We're getting there.
I just have no worries. I have some questions. And this is going back to the vaccine clinics now that are proposed for the middle school. Are you 100% confident stating, and this is really, I know that everybody has a different position on this on the board, most likely. So, take it as you will. Are you 100% confident stating on public record that these shots are safe? Are you 100% confident stating on public record that these shots are effective? Have you thoroughly read through all the Pfizer data and the VAERS data now available? Those are yes or no questions that I have for you. My other questions are, what do you believe is
We lost you, Cardinal. We see you present, but we lost your audio.
Happened.
I'm not sure. We'll try to get you back promoted as a panelist, but for some reason your audio cut out. I wonder if
That's weird.
well, for the sake of time, we'll move. She's back there. Can you hear us? We seem to be having trouble hearing you. We're gonna skip ahead to a couple other people who want to talk, and if we can connect with you at the end, we'll circle back. Matt O'Brien is next. Then we'll hear from one more after Matt.
I think they've all had a chance to talk, right?
This says in speak time, they
They
haven't
can talk multiple times.
on it, yes.
I'm here. My
Oh,
computer
there you
just
are.
disconnected. Yeah, so sorry about that.
That's
So
okay.
I was at, what do you believe is informed consent? And that's a question I really would like to hear from Dr. Ruby especially. And then what is your source for informed consent? Thorough informed consent. And then this one just came up because of the first topic that was brought up, which is I'm really confused as how the legality of the shots is not relevant if you are giving them. I don't understand that, but that, we can wait with that one. That just really confused me. So basically the first three are yes or no questions. And then the last two, I just really would like to understand what you understand is informed consent, what you believe to be informed consent, and what your source is for that when you are giving it. And are all of these people at these clinics able to actually offer informed consent? So that's it. And thank you for waiting. I'm sorry about that.
That's okay. Thank you. Just as you know, this is, a time for citizens to address questions to the board. We're not required or are obligated to answer them.
Okay.
And you can certainly send those questions via email, and if board members feel so moved, they can answer them publicly if they wish. But
Can I just answer the
Sure.
question about the vaccines and the VIS forms, which
Sure.
are the vaccine information forms that are usually, as you well know, I'm a pediatrician, so I've been giving vaccines forever and ever. And with each vaccination by law, we have to give a VIS form. This VIS form, whether the patient's parents requested or not, it has to be given. So, and it has to be updated. So we have to give the most recent VIS form provided by the CDC to the parents or the consenting adult for every vaccine that we give. So having said that, the discussion about whether it's appropriate to give a vaccine is not to be addressed in a public setting like a board of health. It has to be addressed with your doctor who knows your history, who knows your child's history, who can weigh the benefits versus the risk, and then make a decision that is a combined effort of the consenting adult and the primary care physician. So this is not an appropriate place to ask those questions. As you well know, we're providing the clinic as an avenue for people to get their vaccines, but we're not forcing people to go there to get the vaccines. And they are given the VIS forms, and it is offered to them before they get their vaccines. I know that because I was there. So to answer your questions, I think it's an individual conversation that has to take place between you and your primary care, because everyone is
So-
different.
So here's my question though, is your primary care at these clinics?
No. So
Are there
usually-
doctors at the clinics?
So usually what happens is that you would have a discussion with your primary care, and then you can decide where you want to go for the vaccines. So
Okay, I
this is-
just know that I've spoken to quite a number of people who went on the first round several years ago and were not given any informed consent whatsoever. This was in the gym. There was a clinic held in the gym, I believe, at Monument. So I'm just, you know, that's just something I feel is really important. Are they mentioning the risks of myocarditis? Have they really thoroughly gone through all the VAERS data that is now available and the Pfizer data that's now available that was not available several years ago?
That's not true, because when we were giving the COVID vaccines in 21, we knew about the myocarditis even at that point.
But the
So-
Pfizer data wasn't even available at that time.
No, we knew about it. So
But the Pfizer data wasn't available, right?
I think that the initial assessments that they were coming out with that data, yes. So this is not a new information that is just being presented. This is something that we knew about, that we discussed as primary care doctors who are giving vaccines and giving information. Myocarditis was a big issue, and we discussed it with our patients, and we explained to them that the risk of contracting myocarditis from COVID is much higher. It's 3 to 4 times as high as if you were to get myocarditis from the vaccine.
Is
And
that
we-
what the current VAERS data is telling you?
The current data actually has to do with the most recent bivalent vaccine, and that showed no cases of myocarditis. Because what they did was that they found out that the reason the kids were getting myocarditis was because the length between the vaccines were too close together. And it was a little bit higher with the Moderna than it was with the Pfizer, because the Moderna vaccine had, I believe, twice the amount of mRNA properties than the Pfizer.
I think
And so-
I think there's new data out, and we probably shouldn't go back and forth about
So-
that now. I can send you
So
a lot of data that I have.
Can
now.
I just finish my sentence?
Oh, sure.
Okay, so then what they decided was that they now recommend giving, if you are to get the vaccine, especially as a young male, 18 to 36, is that to give it at least 56 days apart. So by giving it in a longer period of time, the most recent data with 600,000 given of the bivalent vaccine, they have found no cases of myocarditis. But you also have to realize that COVID itself is an inflammatory virus. It causes inflammation of your blood vessels. It causes inflammation of your eyes, of your joints, of every part of your body, but it's mainly inflammatory of your blood vessels. So it can cause cardiac symptoms much more frequently than the vaccine itself.
So are you 100% confident that these shots are safe?
I can never be 100% confident with any vaccine.
Are you confident that they are effective?
But I have to balance the risk and the benefits. And are they effective? There's no such thing as 100% effective. Even with hepatitis B, we know that there are people that never respond to it. So it's never 100% or no. It's never one of those cut and dry percentiles. Just like you drive a car, are you 100% sure by putting on your
I think
seatbelt?
that's very different.
Safe?
I think that's very different. And I think we could go down a pretty big rabbit hole with this, so I'm not going to continue with it. I think there's plenty of data out there that shows a very different picture from what you're giving right now. And you know, a lot of us are actually very capable of sending that to you, and we will, and we have. I have actually sent things over the past couple of years and have not received a response. So we'll just continue doing that, and we'll hope that that we
I
can be
think this,
assured that, I'm sorry, that we can be assured that young people and their parents are being told exactly what the risks are, and that everybody who is giving these shots is fully aware of what is in all the Pfizer data that has only been released over the last 3 years, right?
you're
So,
absolutely right. You're absolutely right
yeah,
that they should be informed. They should
yeah.
have that VIS form. They should be aware of what
Well, I'll have a
risk
look at the VIS and
is.
see what's on
But,
there.
but you also have to realize that this is not the forum to discuss this. That the discussion should be between your doctor and you, because your doctor knows your history. I don't know, I would not be able to say, you're absolutely safe to get this, because I don't know who you are. I don't know your history.
I'm
I
not
don't
asking for myself.
know
I'm not
history.
getting the vaccines. I didn't get
But
any
that's
of
what
them, and I've been
you're
healthy for 3 years.
that's what I'm saying, is that these discussions should be made between you and your physician, just like I have with my patients in the
Right.
past.
And I would feel very I would feel very confident, or more confident, if I knew that that was actually happening at the clinics. You know, that people were walking in and being told, well, unless you've actually spoken to your primary, maybe you shouldn't, you know, maybe you should go back, speak to your primary, and then get the shot, because I'm sure that people coming in have not all spoken to their primary before they walk in, because it's all too easy just to walk in, right? It's like a drive-through.
Have you ever registered for a vaccine? There's
Oh,
specific.
no. Oh, no.
Yeah, so when you register, there's specific questions that you have to answer before you can get the vaccine.
Yeah, it's all really interesting. All right. Well, thank you. And it's good to know. And
Yeah.
I will definitely be sending you more
Okay,
information.
okay,
Thank you.
thank you very much. Matt, you're up again. We could make it brief. We're really getting there now.
Okay, I'll be really quick here. Just on the question you brought up about jurisdiction, I brought this up at the meeting with the DPU. Now, as you know, regular corporations, they use a thing called externalities, which it's not our jurisdiction. It's not our job to keep this safe. It's what GE did with polluting the river. You know, it's, you know, they always use it as externalities in corporations. Now, the town of Great Barrington is a corporation. The DPU is a corporation. The state of Massachusetts is a corporation. Now, this is bled in, this sort of externalities where nobody knows where to go to get the accurate data, where to go, you know, who's responsible for this. And in the end, the only reason to be a corporation is to get out of responsibilities using externalities. So I brought this up to the DPU when we had that meeting over the Housatonic water. But what I wanted to say beyond that was that the state now wants to take away the power of the health board. I read an article just the other day that they, you know, they say that the health boards are incompetent and all this. I have to say, with personal, you know, meetings with Michael and Jessica, that I find them very highly intelligent and really an asset to our town. And, you know, I would really object to having the state come in, and it would also cut off our discussions together. So it would do two things. It would take away any power of the, you know, the health department, and then our connections. It's, you know, we'd have to go to some giant organization to do what we're doing here, which is, I think, really great. And I appreciate the health board, and, you know, and I know it's there's a lot of stuff out there right now, water, vaccines, mosquitoes, you know, all of a sudden the world is attacking, and, you know, how do we find out what to do about it? But, you know, as far as I'm concerned, and a lot of other people I know, we appreciate you guys there. And we think that, you know, you're doing definitely the best you can do. And I've found that to be so. And I just wanted, I don't know, have you heard this also, that the state wants to take away the board members?
I've heard some rumors of it, some rumors of that there's, you know, more moves towards regionalization. And I haven't really done a lot of reading on it, but I've heard.
I have an article. I have an article I'll send to you. There is legislation already at the state level where they're trying to do this. And I'll send it out to you.
Please do. Thank you. All right. And
Okay.
thank you for we all thank you for the kind words.
Thank you.
All right. Our last person to speak tonight, Kathy and Kevin Regan. And as I said to Matt, if we've heard from you tonight, if we could make it very brief, seeing as we're across the 2.5-hour threshold.
Michael, we'll do our very best to make it quick.
Okay.
Yeah, we appreciate the time tonight. So just a couple quick things about the vaccines. I know personally, I don't have any confidence in informed consent. We've done research looking at consent forms. We did not vaccinate ourselves. We chose not to, but I wanted to see what was happening because our child was in school at the time, and the consent forms are really abysmal. Big Wise especially, it mentions nothing. So that should be checked into. I'd like to see a little bit more informed consent, especially if there's a doctor on panel at the Board of Health stating that these things are true or that they're, safe in any way, or suggesting. I know Ruby was really good about saying that, check with your doctor, but I also know people that go to these clinics and there's nobody saying go talk to your doctor. So, I think we kind of have to get together a little bit more about the safety of these things and informed consent. And again, I don't like the way that the clinics go around and park themselves everywhere, and people are just kind of able to funnel in and go get this thing without finding out more about it. A couple quick things about the water testing. I know Donna was upset. I don't blame her, but we're very appreciative of you being open to, if we can find some regulatory statutes that will give you more power and oversight. I mean, we're going to look for that because we understand your position and the difficulty you're having there. But there's got to be, I'd like us to all try to think outside the box a little bit. You might not have oversight specifically over residents with the water that are Housatonic Waterworks customers, but you do have oversight with them in every other health capacity as far as any health department would, with any other things that happen in town as far as viruses or anything else. So I'd like us to try to look a little bit further in finding funding. Berkshire Regional Planning Commission, I mean, have you guys checked with them? They have dealt with water issues and helped with funding. They write grants. I've dealt with them myself with the Executive Office of Environmental Affairs years ago. So I do think there's possibilities there. The one thing we are hoping for is independent testing. Some avenue to get DEP approved independent testing, because for the people that have had some testing done, the results are not matching Housatonic Waterworks results. So there is great concern. Their limit for HAA5 is a lot higher than what's coming in with Housatonic Waterworks. The fact that that's only done quarterly is a big problem. I mean, it just came in, quote unquote, as safe. Well, it could already be high in HAA5s right now. So when there has been an ongoing problem, there needs to be some kind of, like amped up procedures as far as doing water testing to make sure people are safe. And the last thing is, the one thing I think you guys would agree that you do have jurisdiction over is notifying people about the contaminants themselves. There's been a lot of HAA5 exposure here, and a lot of residents have no idea whatsoever that this stuff can be dermally absorbed or inhaled. We've talked to the select board about this. We had a really good meeting with the select board, and I think the Board of Health has to be a little bit more on top of helping people understand that just going out and buying bottled water is not going to protect them. They have to have filtration. They can't be doing dishes and inhaling the fumes. They can't be showering in it. It's quite serious, and there is a high cancer rate here. So I'd like to see more notification from the Board of Health and informing people what HA5s really can do, how it can be absorbed, and how they can properly protect themselves. Right now, the select board is getting ready to, hopefully dole out money. It's only a very small amount. A good household filter system is well over 1,000. We bought one ourselves. I think there's going to be like $300 going out to individuals. Well, without guidance from you guys to let them know what to purchase and how to protect themselves, that $300 is going to be wasted. So I think it's really important that you coordinate with the select board, especially with funding that is residents, and figure out a way to better inform the people about what's happening and how to protect themselves. So that's it. That's all I have to say. And Kevin had a few words.
Yeah, I got a couple questions or just comments. That the board with Ruby is representing herself as a doctor, which she is, and that seems to be the assumption that she's authoritative or knowledgeable about stuff, and therefore the board is also. And for Michael's conversation with her earlier tonight, it's obvious she doesn't know what is approved, what's approved for, whether it's emergency, whether it's approved, it's authorized. So for her to say, as far as I know, it was approved is kind of really irresponsible. And also the legality issue doesn't apply to the clinic. I think that's another unfounded statement. And previously, she's on record at other board health meetings saying that myocarditis is mild. And it's not mild if you get it or your children get it. So I think that would just say that statement and not backing it up with other information at the time, which kind of really not too good. And then subsequent meetings where she said, as far as she knew, that masks are effective. People take her as a doctor and a member of the Board of Health as that being truthful or good advice. And at the time, we informed her and asked her, she had no idea what the Cochrane Collaborative report said about masks. All these peer-reviewed studies show that they're not effective. So I don't think that she should be making statements like that without being informed or knowledgeable about. I think her statements are inaccurate, irresponsible, dangerous, and they also leave the town open for liability for people following her statements. Thank you.
All right, thank you both. And that'll conclude our citizen speak time. Is there any media questions tonight? If there is, raise your hand. Not seeing any. I'll take a motion to adjourn the meeting.
I second.
Make a motion to adjourn the meeting.
Oh,
Yes. Then Ruby
I second.
seconds. And well, our final roll call is Peter,
Aye.
Ruby,
Aye.
and I vote aye as well. Thank you. And thank you everyone for your attendance. It was another long meeting and we'll hopefully see you next month. Thank you very much.
Bye.